Welcome to Beneath the Branches, the podcast for the Adoption and Foster Care Clinic where we sit in the shade of shared experience. The heart is normalized and belonging is built, one honest conversation at a time. Adoption, foster care, or kinship placement brings deep joy and real challenges, and we're here to talk about all of it. The hard, the heartwarming, and everything in between. So grab a cup of coffee, take a deep breath, and join us as we hold space for the messy, beautiful work of building connection beneath the branches.
Welcome to another episode of Beneath the Branches. Today I have with me Amy Elmore, who is our feeding therapist, occupational therapist, sensory integration therapist, just overall anything to do with development. And we've had her on the podcast before, but just reminding everybody, like, she's been doing this for 21 years with our clinic. So has pretty much seen it all and developed techniques that really work with our children and a lot of kind of ways to tricks and tips to give to parents. First, let's start with, why do children that come from a history of either trauma or neglect or just difficult transitions, multiple transitions, why would they need feeding therapy?
Well, for the most part, most of them need it, or we don't realize how much they need it, but all of the trauma and things that they've been through in the past, most of them were negative experiences surrounding food. Either there was not enough of it, may have been asked to take it faster than they were ready for. They didn't understand their hunger cues. They may not have understood how they could feel if they actually were full. Some of them associate it with surgeries and surgical operations. Some of it may be not the trust factor of who is feeding them. Mm-hmm. So those are some things that can definitely.
And I definitely see even in the brain development is different in that area, in the area of satiety or that feeling of fullness that we all develop over time. And with these kids, a lot of times their feeling of hunger or feeling of full, it's just out of balance. They just don't know. Maybe they haven't felt full enough, or maybe they haven't felt full at the right times, like when they actually were hungry. And so that it gets imbalances there in the brain. So we're really, through feeding therapy, kind of changing those centers of the brain that deal with
changing those cues so they know when this happens, this is what I get from it. So if you have a child who is especially hungry, but maybe you're doing the food and it's stressing them out, then they associate hunger cues with stress and anxiety, so they turn it away. So it can actually almost provide like an overstimulation because they don't know what good can come from it. So there's a very fine line when you're trying to do some of the feeding therapy. That's one of the stress factors. So I don't want them to be overly hungry when you're trying to do some of that therapy, because if they do, then they're already stressed. That stress hormone's already increased, and they're not able to handle someone coming toward their face with a new food or a spoon or a bottle or a new cup. And because also they're used to, some of ours, have that trauma past where they were force-fed more and they didn't even know what to do with it. So some of them could almost feel like you're drowning because you're getting it so fast, or it spills back out. So you don't have any positive experiences to go with feeding.
And I think it's interesting too, how our feeding and hunger is so related to our feelings of safety and our feelings of attachment. And when you go back to the infancy, what's a baby do? They sleep, they poop, and they eat, right? And so it's such a primal need for a baby and for all of us. But that primal need, the way we're designed is to use that to attach to the people around us and to learn to take comfort in the person who's providing that need for you. So,
and most of our kids don't have that background. So either from being in a home where everything couldn't go just right and the child needs to be taken from a home to be put somewhere else for that time to feel safe. Well, now they've only had the stress of leading up to it. So you have that, you have in an orphanage setting, you have that. And then a whole nother even side of this is that we're talking about what the babies need to be able to eat and what they get. Well, then as a parent, as a caregiver, when we have those opportunities to now feed them, so now we have a child in our home who has a negative background, either in the hospital or in an unhealthy setting, or not having enough food or not having the right kinds of food. But as a mom and as a caregiver, we have an innate feeling and responsibility that we want to feed our kids. Mm-hmm. So when we are not able to do that, it increases our stress factors. So now we're telling a child they see the stress. We're not co-regulating with it because we get stressed out because we want to be able. So I mean, just pulling from my own example, doing feeding for so long, one of my tactics was to tell families to try to make their own baby food. Well, I knew as a mom, I better figure that out as well, because I didn't want to tell folks to do something that I had not done before. So I learned how to make baby food. And I had a friend that was doing it at the time, and I had some different cookbooks. So joke was on me. My second child decided he was going to be a feeding nightmare. And so I was teaching some different classes to nutritionists and trying to tell them about positive reinforcement. And here I had a child who would not want to eat. And even my husband at times would say, would you just let me know whenever dinner's done so I'll come home after that? And I know a lot of our families are already having that happen. Mm-hmm. So just knowing that the stress that it caused on me then did not co-regulate my child, so that then he felt more stressed when it was time to eat. Mm-hmm. And so we went into that cycle. And that can happen with so many of our kids.
Definitely. Mm-hmm. Well, maybe we could too talk a little bit about scenarios, because there's so many kids who present different ways with feeding difficulties. I mean, it's just such a variety. So let's start with, say, the child so they've been in an orphanage or they've been in a neglectful situation. They're 3 years old and they've never had solid food, or they've had very little experience with solid food. Number one, why would that ever happen? That some people find that shocking that actually happens. Right. We see it quite a bit. And then what do we do with those kids? And why don't they just you put a fork in their mouth and they eat it?
Why don't they just eat the food?
Yeah.
Well, first of all, something does happen whenever they're mostly taking a bottle. Mm-hmm. The tongue tends to just go front and back.
Yeah.
So their tongue has not learned how to do other movements side to side. So when they were offered food, or if you're now trying to offer them food, it sits on the tongue, and when they take it, it spits right back out. And a parent thinks, or a caregiver thinks, oh, they don't like it, so they try something else. But through so much of that bottle feeding, or gulping as it is, they never learned how to transition to mash it, to be able to move it around in their mouth. They've never felt texture before. So now any texture, even coming, or smells, it overstimulates them so much, it just coming to their face. They have to then learn to experience it for the first time, but you have to learn it through a safety way of doing it, through that positive reinforcement, because it's now a scary moment. And so many of our kids just don't develop those oral motor skills, and maybe now they're 3-year-olds, so their brain has further developed. They understand more cause and effect. They understand, moving, crying, pinching, pulling hair, pushing away, and a caregiver sees that as a negative response. So then the next cycle begins. Now they don't eat as much, and we turn into this failure to thrive, and our nutrition begins to suffer.
I think you've taught me little tips and tricks. One is just when you're putting the solid food in, dump it into the cheek, don't put it on the tongue. Just little things like that, because that teaches the tongue to learn how to go side to side instead of just in and out.
Right.
So those little tips and tricks go a long way.
Right. And sometimes then they've never even learned how to open their mouth to a spoon. So we've got to even go back to, why would I open my mouth? It's not a bottle.
Right. Yeah.
I know many times we've had to learn just to put liquid on a spoon so that it's the same smell, so they can associate the same formula or the type of milk or whatever it is, the substance they're drinking, to be able to take it through a different source.
Yeah.
So that then they go, oh, okay, that's the same smell. I do want that. And then, of course, they have to learn what to do with it when they get it in there.
I had a lot of our families, and I would have done the same recommendation, 25 years ago would be, okay, well, they're not getting enough calories, they're only getting liquid, or if they're getting a little solid, it's just not enough. Let's start Pediasure to give them extra calories. And so we don't recommend that.
Right.
Can we say, why do we not recommend that? How does that mess up the advancement of our feeding therapy?
Right. I don't want to jump into the highest calorie possible with a sweet source just because that we have a window of opportunity, and there's this fine line that we want to walk with our families to encourage to get some food in, and it may be, we know there's a direct correlation to what mom ate in utero to what they may now want or what they may tolerate. So that we want to think, what is some of those foods, like from those certain countries, or there's certain, in their home, what were some of those smells? So we know we've got to try a few other options to get them to eat. If we go straight into the high calorie, sugary sweetness, it tends to tell them, that's now going to tell them that they're full. So they learn the satiation from that and not from the food. So I want an opportunity, and sometimes we have to do that. I mean, because we know sometimes it's just about they need the calories to grow. And if I can't get them to grow and you can't get them to grow, then their brain doesn't grow, and then we don't have further development. So there are times where we know we need to do some type of formula, but I want the opportunity to try some of the tactics that we use because of that needing that positive reinforcement. The rest of the world may say, let's do some other types of feeding therapy, but I've got a few tactics that I know I can get a positive response from a parent that will work better than going straight into a Pediasure type formula.
And I think, just to clarify, we're kind of mostly talking about in these cases of kids who are newly home, right? And so that window of time is so crucial. And I always feel a comfort if they're making advancements. If they're making advancements, then the pediatrician is going to slow it down.
Right.
If they're not making advances, then I've got to recheck. Okay, let's look at the weight. Let's look at the growth chart, that kind of thing.
And we care about the vitamins and things that they get. I just want the opportunity to see if I can, during their time of attachment and bonding in a family, can we move at it from a different approach? Because, a lot of times we want children to stay on the bottle even longer because there's an attachment piece of that. And if we can get the love, the feeding I can get later sometimes. But every child in every case is so different that we need an opportunity to say, okay, let's do this, but maybe what if we do it in a different way or a different time of day? And we associate maybe the drink after we've tried some solids. But again, every situation is so very specific to that child's needs, their stress factors, what the family might be able to even do, and other family and other children in the home. What else is going on? Is a family need to be on the go? And that changes everything.
Yeah, and I think that's where we kind of rely on each other, and that it makes it a lot easier doing feeding and nutrition work in a team because, say, like you've said, sometimes we do recommend staying on the bottle longer because in general pediatrics, when I was doing general pediatrics, it was always, okay, one year, let's get off the bottle. But because the food is so crucial to feeling safe, what we call felt safety. Sometimes that'll be the strongest form of bonding that is happening between the new parents and the child.
Right.
That bottle. And so sometimes we make crazy requests like, let's go back to the bottle. I know you're 2 years old, but let's go back. But it all depends. There's not a standard line of advice. It depends on where that child is in their attachment, where that child is in their development, and what their child's feeding habits are.
And myself as a feeding therapist, I look at it so differently than other feeding therapists. I know when I started this job 21 years ago, gosh, almost 22 if we think about it, how long we've been doing it. I had to think very opposite of what I would in a medical setting.
Yeah.
In a true medical setting and doing outpatient therapy, I had to take a step back and go, I needed the input of what you saw from nutrition. I needed the input from what does the family therapist say is happening with attachment and other things that we're seeing. And then, of course, their overall development matters. Are they delayed in sitting up? Like those we've had many of those opportunities that come up that we have to think, what can the child's overall motor development even handle? So there's so many factors that we have to go into it that every child, I'm going to have a little bit different recommendation.
Right.
If it's behavior, because maybe they've now been in different foster homes and now they become this picky eater, I've got to figure out, well, how do I do this? Because they want complete control over what they're going to eat. So I've got to look at it from a different perspective and not just one way of looking at how you do feeding therapy. I take in all 5, 6 different courses I've been to over the years, and I might use 6 different tactics in 5 minutes.
Well, let's talk about that, like the picky eater. Let's talk about the picky eater scenario.
Okay.
You know, either they're newly home or they've been home for a while, you know, because those, I feel like we treat a little bit similarly,
Right.
you know, versus the other ones. But a picky eater, that's very frustrating. Like you mentioned, as a parent, you get frustrated that you're not able to provide what the child needs. Maybe they're not gaining weight. You're stressed out.
Right.
Why the picky eating? And maybe I know there's a lot of techniques that you use, but maybe just a couple.
So first, one of my favorites is finding that point to where they can tolerate being pushed. So within an evaluation and assessment time, and even those first couple of sessions, I've got to figure out what is really happening during it. Is it their need for control and the anxiety piece that's kicking in?
Right.
Is it that they maybe can't sit long enough to sit and enjoy a meal? You know, are they looking at what else might be going on around them? Are they on the go a lot? So picky eating can kind of happen just because we're on the go. You know, a lot of our families, we've got a lot going on. Is the TV on in the background? Sometimes that helps. Sometimes that hurts. You never know. But with picky eating, one of my favorites is to find that line of where I know I can push. So sometimes it may just be setting the food in front of them, and we call it having a tasting party. So let's just have a tasting party. Let's see what can you tolerate being in front of you with positive reinforcement. But I've got to have buy-in from the family. So in those cases, I tell families, I'm going to push. I'm going to find where that line is, and then the family needs to maintain where we got to. So it may take them a week or two to work on that at home. But if I look for all of that follow through. I know families need to figure out how can they do this same feeding activity at home with the same amount of push that we just accomplished, but not go any further. So then they may need to come back. There's, a lot of different therapies. I'll tell families, it's okay if you want to come in weekly. And if you need to come in more often because you need that little push. But if a family's not able to really make it happen at home, we're really not going to make, especially with a picky eater, we're not going to be able to get it to the next level. So my job, I sometimes find, is that parent coaching perspective of how do I help a family feel empowered to make these little sessions happen, even if they're just for 10 minutes.
And I think it's really crucial to find that stress point, because eating is so closely linked to attachment. And so if we push them too far, then we might interfere with attachment.
Right.
If we don't push them far enough, they may not make gains.
Right, and then they'll take forever. Those are we've had families that have said we've been doing feeding therapy for 6 months to a year, and some of the goals have just not changed. So there's a healthy balance we have to find, and I have to know that the family's okay with finding it. Because that's stressful.
That's okay from our family therapist. Like, hey, you can stress this one a little bit more. Or I might be, you need to stress them more because our nutrition is really in peril here.
Right, exactly.
All right, let's talk about the scenario of what I call our vacuum cleaner babies, where they're just eating everything. And these are, again, in the newly home phase. Right? We have some later, and we would handle them differently when they've been home for longer. But when they're newly home, or you're still in country with that child, they're just eating as much as 2 adults put together.
Right, they sure do.
They do. What causes that? What do we do about it?
Well, and I learned mostly from both of y'all, but they're eating because they never had it readily available before. So I know from what I've learned from you and the family therapist is we want them to eat as much as they can.
Yeah.
And it is probably going to make their tummy hurt. And it might make them throw up. But we kind of want them to hit spot, right?
Yeah, of feeling that full. That's like that after Thanksgiving. Oh my goodness, I shouldn't have done that feeling, right? I shouldn't have eaten so much. And then, you eat the leftovers later, but you don't eat quite as much. And then the next day you taste it, but you don't eat quite as much because it felt miserable to be that full. And our kids need to have, those kids that are overeating need to have that feeling.
Right.
And that's why we even say, and most don't eat to the point of throwing up, but we always tell parents, like, that's not the end. That's not a terrible thing. We don't want them to do that, but it's not a terrible thing if they get sick afterwards in the beginning when you're letting them just go, because there's like, 3 things you really cannot control in a child, no matter how hard you try. It's when they, how much they eat,
what they're eating,
and
sleep,
sleep and toileting.
Right.
You know what I mean? We can guide, but they can control it. And, individually for themselves, in the end, that's who's controlling it. So we want them to control and slow down their own eating pace.
Right.
And especially like if you're in country still, if you're an international adoption, we don't even really care as much what you're eating at that point.
We just want you to survive those episodes.
And then, but once you get home, then we always say the parent can decide what they're eating, but the child decides how much.
Right.
So if the child's malnourished and they're overeating, great. That's wonderful to catch them up. We need their nutrition to get caught up. If they're not malnourished and they're overeating, the temptation is to take the plate up and not give seconds, that kind of thing, or not to offer snacks. But that isn't the best way to control it, and it will make it worse for years.
Right, and it just increases their anxiety along with it.
Their anxiety.
Sometimes I'll even see an oral motor skill problem because if they think now they have to eat it faster because you're going to take it away, it now causes this like a pocketing problem, or they overstuff. So then guess what happens from a sensory perspective? They think they have to have more food in their mouth to feel it, because maybe they also didn't have it before. So now they went from not feeling food in their mouth because they weren't fed to too much. And so there's this, I need more. I need that deep pressure to know how to do it. Well, then they may begin to gag or they choke more. And so then they learn how to mash it almost with their tongue, and then they kind of swallow or gulp it. So now there's a new oral motor skill problem. Or now they've left it and they pocket it for later. We see that quite often, especially from out of our foster care and domestic adoptions, because of that same concept. So now you have a new oral motor skill problem that created from it, rather than realizing it and regulating it over a smaller time period.
Exactly. Yeah. And I think it's fascinating to me after, so many years of seeing this, that if you do let them, in the beginning, just eat, how quickly they slow it down.
They do.
It's fast. And I tell people, like, if they're still doing this after 2-3 months max, then we've got a bigger problem.
Right.
But the majority, 95%, 98%, you let them go and have the quantity of food that they want, then they slow themselves down.
And it may even be that they need more food from their background, from that country. Sometimes we try to have them eat what our other kids are eating in our home, or how we eat. And that makes a whole new limitation, because a lot of our kids aren't used to things being cold.
Exactly.
And they're used to, we've had some extreme temperatures of kids used to food being, I'll never forget having one episode of a child with a bottle, and, we test our bottle, on our wrist to see what the temperature is. And this child had been so used to being it super hot. I mean, to the point that it would scare us.
Yeah.
But we had to wean off of that, because if they didn't feel the heat, then they didn't identify it as food, and so they didn't eat.
I mean, that's a really common, temperature's a really common issue. Again, we're not talking about now the hoarders or the
I moved on to the other, to the other newly home kiddos.
Yeah, I mean that sometimes if they're avoiding eating, it might be a temperature thing.
Correct.
Because in some orphanages, there's not refrigeration.
Right.
Or we've got to save that refrigeration for the meat, so we're not going to, the yogurt's not going to be refrigerated, the ice water's going to be room temperature, those kinds of things. And so that's really important. And then also just on that vein of kids that are just transitioning from another country, it is important to offer at least the foods of their country, because their taste buds are kind of set up for that.
Right.
And if they don't accept it, fine. Then you just offer them what your other kids are eating or what you're eating, but then always go back to it later, because after they're out of that time of stress and anxiety, they may be more open to it. And so that they can maintain also some of that culture. And, you don't have to always make the foods yourself. You can just go to your local, say, India restaurant, get several dishes and put some in the freezer.
Costco's got some great ready-to-eat packaged dal and lentil things. Yeah,
they do. Amy's is another brand that have great stuff. So we try to kind of keep up with what are the easy international foods for our international adoptees that parents can do in a time of stress to kind of help those kids out.
And I think that's one even for families who are getting ready to travel. They sort of have these ideas set up about, I'm going to pick up a 2 or 3 year old, and if we didn't do a pre-adopt or they didn't have the opportunity to learn ahead of what a child might do when they get there, it's a little scary, because I know we've spoken to families at night before on the phone. Well, it's nighttime there, daytime here, or opposite, to help them know what to offer in country, because they're shutting down and not eating anything.
Which reminds me that another good thing is to, when you're visiting your child's orphanage, is to ask to watch them feed.
Right. If you can see what it looks like.
You can see how they prepare the food. What does the food look like? If there's a bottle involved, how they prepare the bottle. What is the size of the little nipple, the hole in the nipple of the bottle? Is it like a fast flow, or is it a slow flow?
What does the spoon look like? Is it a serving size spoon?
Yeah.
Is it a small little spout? Is it look like something you would measure food with? I mean, we've had so many different things, and that attributes to even when I'm doing oral motor therapy, I have to present things very differently than you would in another type of setting. So I need to be able to go, okay, what did that look like? So that's going to be one of the things I ask. Or did they mostly eat with their fingers? Because that's going to change the type of texture. It's going to be different on how I offer food, how a parent offers food, and how I teach them to offer that food. So yeah.
Now, kind of moving down the line of kids who've been home for a long time and still having feeding difficulties. I mean, that's kind of too in-depth to even to go to, but on a podcast. But I do feel like there are some signs that you might see, okay, you need to get intervention at this point, so.
And that's kind of where the behaviors creep in.
Yeah.
A lot of times families will think, that there are certain things they don't like, but it might be something that happened from their past, that maybe those are the comfort foods, and so now they become picky eaters, or the behavior of maybe if there was reflux that was untreated. And now it's not an issue anymore, but they attribute pain to eating. So those are kids that now have new behaviors set up. Some of those issues aren't still there, but they have the core memory of it. And they have the behaviors that correlate to the different foods that may have caused problems, but they don't know that it doesn't cause problems. So I see that a lot. I know even one more of my specialty is just that behavior strategies, because I'm looking more for positive reinforcement, less stimulation, and it's a lot of parent coaching, parent training that we have to do, and that's something that we offer, even to do over telehealth. Just giving those opportunities to learn how to do that in their home setting. But needless to say, the behavior regulation part of it, and then there's a sensory aspect. So I've got to tease out which one it is. If I only approach from a sensory perspective, then I'm not going to make progress.
I think another key behavior that we want people to reach out to us before is if the child's eating to a point that you're having to lock food up.
Right.
If you're having to lock your pantry, if you're having to lock your fridge, that should be an automatic, hey, I need some help, because probably this is more an emotional, behavioral, but it could be a medical issue.
Correct.
It could be something that we need to look for, things like ADHD or autism, but it also could be just a deep-seated anxiety or some lingering difficulty with attachment, things like there's so many things that can cause that, but that's an immediate trigger to call us.
And another trigger is if you notice that the child only likes to eat it from a certain package.
Yeah.
So we've got a lot that when they move homes, so like you're going out of foster care or into different homes, like from a kinship adoption, they're used to what they had at home or what you did offer at first, because that's where they needed that safety net. And so all of a sudden now, if you feed out of certain packages, but sometimes that's why certain pouch food kind of bothers me, because it's a quick fix. But if they only want the pouch food that's green, or if they only want the chicken nuggets from the brown package, well, we don't know what happens when Tyson changes their packaging. Then they're like, wait a minute, how do I still get it? It's because there's a comfort in because that is straight up anxiety and anxious behaviors around the food, it needing to be the same.
Yeah.
And so those are things that I have happen often, and then those are things that we discover through a referral that sort of began the process. And now I'm looking at it going, okay, how do we present the food differently and letting them know they're still safe?
One thing I just want to cover is that, kind of how we've been pushing a little bit more to have you be able to do this for people outside of our state, or people outside of our driving, or even within driving distance, or people that it's just too stressful to get out of their house and bring their child.
To get them in a car seat.
Because we've been really playing around with this since COVID, about how do you do this parent coaching around feeding virtually.
Right.
So tell us kind of, how do you set up a virtual visit?
Okay.
How does that go? What's the success?
Well, we really did learn how to do that through COVID for the most part. And more of what I do in person is I might be pushing, but I always end with the mom or the parent, caregiver, doing the feeding session. So through telehealth, if we set up kind of a parent coaching session, I'm watching on their end, even if a child is sitting in the high chair or they're sitting in their lap. I had some very great success from just watching. There was one parent that said, I got to see every room in her house. I think I saw the bathroom, the living room, the kitchen, and to the master bedroom is where we had the most success. But, just sitting in the mom's lap in front of one of her long, stand-up mirrors. And I was able to watch and give her ideas to do. But I very much coach what to do next. If a child is upset, or hand placement. Sometimes it's just feeling that security of, if you put the hand on the head, did you put the hand on the chest? Did you hold their hands? And letting them know through less stimulation. Because as parents, we tend to want to, especially now our new generation, we talk through things. And one of the hardest things I want parents to realize is we don't have to talk through it. We can show it through emotion, or our facial gestures, or a toy that is close by, or music that is playing. But I have loved doing the parent coaching. I've had some of the most success because I'm putting it in the parents' hands, the knowledge, and then they try it, and then we meet back a week, 2 weeks, 3 weeks later, however long they need to be able to have that success. But I'm just coaching them through how to regulate their child. It's not occupational therapy, but it's parent coaching. It's using all these strategies that I've learned through the years by being in this clinic and by being in other settings, how to help parents be better parents.
And I like, too, that then it's more widely accessible, because this is such a niche situation. Do you know what I mean? It's feeding therapy for a child who's had trauma, neglect, and all these different scenarios that our kids we've seen over the last couple of decades. So it's so niche that it's just nice to be able to say, okay, if you're in Washington State and this is you, we can still get to you.
Right. I've got families I'm helping in Oklahoma. And we've had such great success with it, because the families having to deal with their other family in the home at the same time.
Yeah.
I mean, one of the things we know we have to do is I want to set a parent up for success.
Yeah.
And if I'm not doing that and they're not able to do it in their own home environment, there's, I always used to say I have no magical powers, but I have all these ideas, but I have to see the certain case scenarios to know how to come up with what should happen next. Yeah. They've been the most fun. I really, just because we've had the most success with it.
Yeah.
And when we do that, and if I bill, we bill for the time.
Yeah.
We can set an hour, but if all we need is 30 minutes, then it's a fee for service, but the family doesn't have to pay. It's not the full price.
Right, yeah.
Right. I want to do what works best for the family. My heart has always been, I have high empathy for what's going on in a family home. I want to see marriages not fall apart. I want to see homes and families thrive during this. And we know, and they may not know, how stressful all of that scenario is. And if I can just make their life a little easier by decreasing a mom's stress, then we know we can do it.
Well, thank you very much.
You're welcome. This was my favorite.
Yeah, we'll come back and talk about your other areas of expertise in a little while.
Okay, thank you.
Thanks.
Thank you for joining the Adoption and Foster Care Clinic for another episode of Beneath the Branches, a podcast for adoptive, foster, and kinship care families. We are deeply grateful to our sponsor, Show Hope, for their generous support and their continued work to break down barriers to adoption and support families every step of the way. Until next time, may you feel covered, connected, and never alone beneath the branches.